Respected Chairperson, teachers, and my dear colleagues. I am Dr. Jaimon PM, Assistant Professor, ESIC Medical College, Paripalli, Kollam, Kerala. At the outset, let me thank the organizers for giving me the opportunity to present my paper titled A Study on Depressive Disorders Among People Living with HIV/AIDS in Kerala. It is with great pride and honor I stand before you to present my paper. As we all know, HIV infection initiates a long and complicated physical and emotional processes leading to various medical and psychiatric complications. Among patients with HIV infection, depressive disorder is the most frequently observed psychiatric condition, and the prevalence rate ranges from 20 to 80% in various studies across the globe. Severe depression can cause significant loss of function and marked diminution in the quality of life. It can influence the physical well-being and lead to a higher risk of progression to AIDS diagnosis. It affects their day-to-day functioning, their ability to manage their illness, the immune system, and even their survival rates. And people with depression and HIV have increased mortality and will have faster disease progression and decline in CD4 counts. It will lead to lower levels of adherence to medication and development of drug-resistant HIV. The primary aims of my study was to compare the prevalence of depressive disorder among people living with HIV/AIDS and people without HIV, and to analyze the difference, if any, of the psychopathology of depression in people living with HIV/AIDS and people without HIV. The secondary aims were to assess the psychosocial-demographic profile of the people attending Integrated Counseling and Testing Center, that is JODIS, and to investigate the psychosocial factors associated with depression. Materials and methods. Persons seeking help from JODIS attached to the Department of Microbiology in a tertiary care center in Kerala for 1 year who are detected to be HIV seropositive were taken as the test population. JODIS Center is an integrated HIV counseling center where HIV patients are identified and referred for medical evaluation and treatment. Psychosocial management is given by trained counselors. The study was approved by Institutional Review Board. The inclusion criteria were persons tested to be HIV positive with 3 different ELISA tests, age group 20 to 60 years, subjects who provided written informed consent, and age and sex comparable HIV negative individuals were taken as the control group. Exclusion criteria were subjects with any significant neurological disorders, including traumatic brain injury, subjects with any other significant chronic medical illnesses like diabetes mellitus, hypertension, seizure disorder, etc., subjects with a history of any psychiatric disorders extending to the period of study, subjects with dependence on alcohol and other substances except nicotine. The materials I used were a specially designed personal pro forma with written informed consent, clinical assessment by general physical examination and mental status examination, Kupusamy scales to assess the socio-economic class, general health questionnaire 12, diagnostic criteria for research as per ICD-10 for depressive episode, 17-item Hamilton Depression Rating Scale to assess the severity of depression, and a modified 11-item Hamilton Depression Rating Scale to rule out the somatic symptoms which may overlap with the symptoms of HIV infection. Coming to the results, 3,157 individuals attended JODIS during the study period. 1,604 were males, 1,352 females, 117 male children, and 84 female children. Out of this, 5.5%, that is 174 individuals were tested to be HIV positive, 86 males 77 females, and 11 children. Out of the 163 adults with HIV positivity, 97 individuals satisfied both inclusion and exclusion criteria and were taken into the study. 100 age and sex matched HIV negative individuals were taken as the test sample. Now coming to the socio-demographic profile between people living with HIV AIDS and HIV negatives regarding sex distribution, the marital status, the religion, the socio-economic class, and the family type, there were no statistically significant difference with all p-values greater than 0.05. Now coming to the prevalence of depression, 47 out of the 97 HIV infected individuals were diagnosed to have depressive episode, whereas 12 out of the 100 HIV negatives were satisfied criteria for depressive episode with a p-value less than 0.0001, which is statistically significant. And on assessing the mean ranks of the scores of GHQ-12, HAM-D17 and HAM-D11 by Mann-Whitney and Wilcoxon W test, the p-value was found to be less than 0.0001 and it is statistically significant. And about the socio-demographic profile of depressed people living with HIV AIDS and depressed HIV negatives regarding the sex distribution, the marital status, the religion, socio-economic class, family type, and family history of psychiatric illness, there were no statistically significant differences with all p-values greater than 0.05. Now regarding the psychopathology of depression among depressed PLWHA and depressed HIV negatives, 18 out of the 47 depressed PLWHA express ideas of guilt and 1 out of the 12 depressed HIV negative express ideas of guilt with a p-value of 0.047, which is statistically significant. 40 out of the 47 depressed PLWHA had death wishes and 7 out of the 12 depressed HIV negatives had death wishes with a p-value of 0.047 and is statistically significant. 16 out of the 47 depressed PLWHA had history of deliberate self-harm, but none in the depressed HIV negative had history of deliberate self-harm with a p-value of 0.018 and is also statistically significant. Coming to discussion, significant differences in the prevalence of depressive episode among people living with HIV AIDS and HIV negative individuals are found in this study, that is 48.5% versus 12%. Prabha S. Chandra and colleagues has reported a 40% prevalence of depression in HIV infected individuals in a study in South India. Fiona Jode and Angelo Committee has reported 50% prevalence of depression in HIV positive individuals. Significant differences in the scores of GHQ-12, HAM-D17 and HAM-D11 are present. Attempts of deliberate self-harm, death wishes and ideas of guilt are being significantly more common among depressed PLWHA. And a study from Jyoti Center in Pune has replicated similar findings. There is not much difference in the prevalence of depression considering the sex, marital status, socio-economic class, religion and family type of the individuals of both groups. And it is contradictory to the finding that studies in India have reported higher rates of depression among women compared to men, and it may be due to the higher female literacy rate and easy healthcare accessibility in the state of Kerala. Limitations: current study only looked into the depressive disorders in people living with HIV/AIDS, the disease state, the antiretroviral treatment status, and cognitive impairment were not considered in the study. Future directions: psychiatric screening should be routinely integrated in all HIV clinics. People with HIV/AIDS should be carefully interviewed for death wishes, suicidal ideations, and ideas of guilt, and they should be targeted by the suicide prevention program. Antidepressant treatment is necessary, which will surely reduce the morbidity and mortality among them. The relation between depressive status and the immunological status of people living with HIV/AIDS warrants further studies in this area. To conclude with, significant differences in the prevalence of depressive episode among people with HIV/AIDS and HIV-negative individuals are there. Attempts of deliberate self-harm, death wishes, and ideas of guilt are more common among depressed PLWHA. These are few of my references. Comments and queries are well appreciated. I take this opportunity to thank all my patients and their family who have participated in the study. I extend my sincere gratitude towards my co-authors, Dr. Saibinisa BVK and Dr. B. Jaylega, my teachers and my seniors for their wholehearted support throughout my career. I thank my family and friends for their care and support, and I thank you all for your patient listening. Thank you.